Hello everyone, I am Dr. Juma Vishwas. Today I am going to present very important topic of MRCOG Part 2, that is NHS Cervical Screening Program. And it's very important, and if you go through the screening program guideline, you will see that recently they completely changed the guideline and nowadays it's very difficult to understand. So what I'm going to do in today's video, I will only describe how we will do the screening program and when we refer the case to the colposcopy. In my next video, I will discuss how we will manage an abnormal screening, and in my third video, I will discuss how we will manage abnormal screening in different conditions like pregnancy or immunocompromised patients. Before starting today's video, I will request you please subscribe my channel and to get updated. And if you have any queries, you can ask me on the comment box. I'm happy to answer all of your queries. So let's get into the topics. So you know that nowadays in the UK, almost all of the women, we do the screening program. And if you can see that from 2018 to 19, approximately 3.4 million women were screened in England. And why this cervical screening program is important? As because only by doing the cervical screening program, we can prevent the progression to the cervical cancer, and we can also diagnose cervical cancer in very early stage. So we can reduce the mortality, morbidity of the woman. And when we will start the screening program? At the age of 25 years age to 64 years of age. So when the woman is 25 years of age, from GP, they will get a letter for invitation for screening. From 25 to 49, every 3 yearlies, they will get the invitation. From 50 to 64 years of age, every 5 yearly, they will get the invitation. More than 65 years of age, if their previous screening programs are normal, in that situation, they can cease from this routine screening program. So always remember that we'll start from 25 years of age, below 50 years, every 3 yearly, more than 50 years, every 5 yearly, they need to do a routine screening. So nowadays, the terminology is also changed. So previously, it termed as a borderline changes. Nowadays, it's termed as borderline changes in squamous cell and in endocervical cell, mild dyskeratosis, borderline changes with coilocytosis. Nowadays, is termed as low-grade dyskeratosis, moderate dyskeratosis, or severe dyskeratosis. Nowadays, is termed as a high-grade dyskeratosis. Severe dyskeratosis, query invasive, is termed as a high-grade dyskeratosis, query invasive squamous cell carcinoma, or glandular neoplasia. It's termed as in glandular neoplasia of endocervical type or non-cervical type. So regarding the referral we get from the GP, so what is the time frame actually we get that? So if you see that there's 3 consecutive inadequate sample, nowadays it's changed, so it's 2 consecutive inadequate sample. They should offer an appointment from a colposcopy within 6 weeks. Borderline, low grade, in that situations, they can also get referral within 6 weeks. High grade changes or query invasive squamous carcinoma, they will get within 2 weeks. Query glandular neoplasia, the same thing they will get within 2 weeks. But cells of other origin, abnormal cervix, or any symptomatic cervix like postcoital bleeding, intermenstrual bleeding, they will get referral within 2 weeks, but that's for gynecology assessment. So you also know about the HPV, that is human papilloma virus, that is responsible for cervical cancer, some vulval and vaginal cancer. And there are 200 subtype of HPV, but few of them are very high risk. So when we do the screening program, we only see on the high risk HPV because 60 to 80% cases they are related to the cervical cancer. And among 80% of the women will get this infection throughout their lifetime. And even they only have one-time sexual exposure, they can get infected. But the good thing with the HPV is that They don't need to do any kind of treatment for that. They will, their own body, own immune system can get rid of this HPV infection. So let's talk about the screening program. So previously only we look on the cytology, but nowadays they emphasize on the HR-HPV test. So if they see on the HR-HPV test and if it is negative, then they can refer them to the routine recall. But if HR-HPV test is positive, then they only look on the cytology. So if the HR-HPV test is positive, only they look on the cytology, and if the cytology is negative, then they can repeat the smear in 12 months. But if any point cytology is abnormal, they refer them to the colposcopy. In 12 months, again they repeat the smear. If our HR-HPV test is negative, then they can discharge to routine recall. But if it is positive, then again they look on the cytology. Cytology abnormal, then they refer back to colposcopy. But if they see that cytology is negative, then they again repeat the smear in 12 months. After that, if there is a persistent HR-HPV test positive after 2 years, is even her cytology is negative, in that situation, they should refer to the colposcopy. So irrespective of their cytology report, persistent HIV positive for 2 years, then they should refer to the colposcopy. If they are negative, then they can discharge to routine recall. So always remember, 3 times you have to refer the case to the colposcopy. One is that when you see the HR-HPV test and your cytology abnormal, refer to the colposcopy. Second time the things, and persistent HR-HPV positive, even after 2 years, irrespective of our cytology report, refer them to the colposcopy. But if you see that HR-HPV test is positive, but cytology negative, then you can repeat the smear in 12 months. Sometimes we see that there's an inadequate sample. Like if you see that HR-HPV test results is unavailable or cytology is inadequate, then you can repeat it after 3 months. So if any point, if you see that the HR-HPV test is unavailable or if you do the cytology that is inadequate, you can repeat the smear after 3 months. But 2 consecutive HPV unavailable or inadequate cytology, also you have to refer the case to the colposcopy. So 3 times you have to refer to the colposcopy. One is HR-HPV test positive and cytology abnormal, one thing. 2 thing is that persistent HR-HPV test positive, even after 2 years, irrespective of the cytology, you have to refer to the colposcopy. 2 consecutive HPV unavailable or inadequate cytology, you also have to refer to the colposcopy. So always remember, in these 3 situations, you have to refer the case to the colposcopy. So when we look on the colposcope actually magnify the cervix. And what are the things we actually look on that? So you can see that this is the new squamocolumnar junction. This is the os. So this is the columnar epithelium. This is the new squamocolumnar junction. And this is the old squamocolumnar junction. In between the areas, we actually call the transformation zone. Okay. So this is the transformation zone. Okay. So within the transformation zone, then we use 2 type of solution. One is acetic acid and one is Lugol's iodine, just to see any kind of color changes within the transformation zone. If any color changes, then we take biopsy from there. So when we look on the colposcopy, we can tell them either it is satisfactory or unsatisfactory based on the transformation zone. So transformation zone, when it is fully visible, that is on the ectocervix, then we term it as a type 1. When it is incompletely visible, when it is visible, but it's a part of them within the canal, then we can term it as a type 2 transformation zone. Type 3 is that when it is completely hidden and within the canal and we can't see, that is we call type 3. So when we see that is a type 3 transformation zone, we can term as an unsatisfactory colposcopy, but type 1, type 2, we can term it as an satisfactory colposcopy. Okay, so these are the things we look on the colposcopy. So when we see on the cervix, we see the transformation zone and old and new squamous columnar junction. And between that, this is the transformation zone. And we use two dyes over there. One is acetic acid and one is Lugol's iodine, just to see the color changes. And then we took the biopsy and we can tell whether it is satisfactory and unsatisfactory based on the transformation zone. Type 1, type 2 is satisfactory, type 3 is unsatisfactory. So in case of colposcopic examination, satisfactory means adequate, unsatisfactory is inadequate. So when we happy that it is adequate colposcopic examination, and on the impression of the colposcopy or even when took a biopsy, it doesn't confirm that there's a CIN. In that situation, if the patient referred because of low-grade dyskeriosis or less than that, we can refer them to routine recall. But more than or equal to high-grade or borderline changes of endocervical type, in that situation, you have to discuss the case within MDT so that they can review the smears and biopsy and they can discuss the management plan. Okay, so no CIN is diagnosed or no colposcopy impression of CIN1. Index cytology is less than equal to low grade. You can refer them to routine recall. But if you see that cytology is more than or equal to high grade or endocervical borderline type, discuss this case in the MDT. But any abnormal biopsy of CIN, based on the CIN, you can manage. We will discuss this in our next video. Regarding the inadequate sample, that means, as I mentioned, that if the transformation zone is completely hidden, you can't see over there, then in that situation, if your cytology is less than equal to low grade, you can repeat the colposcopy in 12 months. And if there's a persistent inadequate colposcopy, you can offer her for late procedures. However, if you see that patient referred because of high-grade or borderline endocervical type and her colposcopic impression is inadequate, in that situation, you can offer her LETS procedures. Okay, so this is the way we actually manage. If it is adequate, based on her biopsy and colposcopic impression, we manage. If it is inadequate, we can repeat it in 12 months. If this cytology is less than equal to low grade, we can, if persistently inadequate colposcopic examination, we can consider LETS procedures. If we see that patient is actually referred because of high grade or borderline endocervical type, then we can do the LETS procedures. Okay, so let's discuss one question so that you can understand properly. So you can see that this is 35 years old lady, para 2, and smear showed with high risk HPV positive with mild dyskeriosis. What would be your plan of management? Repeat smear after 1 year, refer to colposcopy, discharge her to routine recall, offer LACE, and offer hysterectomy. So we know that when there is an HR-HPV positive, we look on the cytology. If abnormal cytology, we refer them to the colposcopy. So the answer is refer to the colposcopy. So, but if you see that HR-HPV positive, but the cytology negative, then you can repeat the smear after 1 year. But if you saw that there's a persistent HR-HPV positive even after 2 years, in that situation, also you have to refer to the colposcopy. So we today's, we know few things from here. One is that when we have to start the smear test, that is from 25 to 64 years of age, 25 to 49 years every 3 yearly, and more than 50 years every 5 yearly you have to do. 3 times you have to refer the patient to the colposcopy. One is persistent HR-HPV positive even after 2 years, HR-HPV positive with abnormal cytology, and the third one is that 2 inadequate sample. In that situations also you have to refer to the colposcopy. The next things we know that when we term it as a satisfactory colposcopy and unsatisfactory colposcopy, and how we're going to manage accordingly. So thank you all for listening these videos. If you have any questions, you can ask me. And to get updated of all of my video, please subscribe my channel and share with others so that everyone can get help from there. And from my next video, I will discuss how we will manage the abnormal smears and what will be the follow-up. So thank you for today.